We often hear from patients that they believe that one of the areas of greatest unmet need is the gastrointestinal tract. And interestingly, acid reflux, as we've heard, is one of the first presenting symptoms. And therefore, maybe we should be paying more attention to that in the very beginning, along with Raynaud's, and work with our general practitioners to help them to identify those red flags and not to be so dismissive of Raynaud's. But today we're very fortunate to be joined by Dr. Charles Murray, a consultant gastroenterologist at the Royal Free Hospital, who's got a special interest in GI and systemic sclerosis. This session is going to give us an overview of the current diagnostic and management advice and strategies, as well as giving us some practical symptom management strategies. Thank you.
Hello everyone, thanks so much for having me here. It's nice to be back again. I've done this a few times, but not for a while. So I'm talking about dealing with gastrointestinal involvement in scleroderma, and work with Professor Denton here at the Royal Free doing that, and would have seen some of you, I think, we met outside. But it's worth saying that it's incredibly interesting coming after Marco's talk, of course, because gut symptoms in scleroderma do present very early. And of course, gut symptoms in the general population are also very common. And I think it's recognising patterns in patients, and as you were saying with general practitioners, that may be helpful in the future. And I think it's often interesting to find that people have been suffering with gastrointestinal symptoms way before they present with scleroderma, and also that potentially, and I'll talk about this in a second, why I always feel somewhat limited by the time I get to see most of the patients that I do see with scleroderma, because many of the effects on the gut have already happened before we get there. So looking at this, if we think about GI involvement being in systemic sclerosis being up to 90% of patients, that's from when we survey patients and when we look across the literature, maybe even higher than that. The 90% really is those that have esophageal symptoms, so whether they be reflux, regurgitation, or difficulty swallowing, or all of the above, brings us up to around 90%. But as I'll talk to in a second, can affect any part of the gut, really from the mouth to the bottom, to the anus. It can be really troublesome. It's not always symptomatic at the beginning, as has been alluded to already. When we do look for abnormalities, especially in the upper GI tract, which we can do relatively easy with manometry, they're very often present before people are aware of them. They can occur at any time during the illness, so we sometimes see patients that are relatively asymptomatic that develop symptoms later, but more often than not, there will be some symptoms if you ask for them. And that's important too, especially when I'm talking to other gastroenterologists and physicians, because things like lower GI tract symptoms, incontinence, embarrassment, problems when patients are out socialising are things that aren't necessarily asked about in consultations, maybe because people are too hurried or they don't want to open Pandora's box of what they're going to do about the problem. But it's a real issue and it does need to be asked and dealt with. Severe involvement actually happily, certainly when we look across all of the population, is not the majority of patients. And the increased morbidity certainly there is to do with gastrointestinal symptoms, and the mortality tends to be with those at the very severe end of the spectrum, where the gut is ineffective and is not working properly at all, and we then lead to things like intravenous nutrition. Now, looking at this diagram here, you'd be a bit sort of terrified if you're a gastroenterologist to where you're going to start with systemic sclerosis, but rest assured that not everyone has all of the symptoms. As I said, if we look at the top left there, esophageal symptoms do affect up to 90% of patients, and they are really a whole host of those. The most common definitely being reflux and regurgitation, being so bad sometimes causing choking, and of course that feeling of food sticking. And we know that's because of the very typical way that scleroderma affects the gut, in that it affects the smooth muscle predominantly in the esophagus, the lower 2/3 of your esophagus, so you are able to initiate swallow, then the food is just working with gravity thereafter. And of course that's a very distressing symptom to have, and is actually very difficult to treat. And I'll keep coming back to this, but why is it difficult to treat? It's difficult to treat at the moment because we don't have any treatments that then bring the muscle back to life and make the peristalsis work and get rid of that symptom. So we're dealing with what we can do, which is to suppress acid, treat any bacterial overgrowth, try and increase the motility lower down in the gut. But the esophageal symptoms become very difficult to treat for that reason. There can be mechanical problems in the esophagus. We used to see a lot more before acid suppression, but we see much less in the way of damage, true damage to the gullet and stricturing, which used to be a very common symptom in the disease. Within the stomach, we see problems with motility and gastric emptying. They tend to happen, I would think, very early in the disease, but also some secondary vascular effects like gastric antral vascular ectasia, so lots of tiny vessels in the bottom of the stomach that can bleed quite easily and make anemia a presenting complaint in that condition quite often when people aren't even aware they're bleeding. We can treat it and do, so it's worth knowing about. And I won't go into all of these individually because I'm going to talk about some of them in the slides that come. But just as you can see, small bowel, the bit of your gut between your stomach and your colon, up to 7 meters in length, hugely complex because, like gastroenterologists, the GI tract is very complicated. Joking aside, it is very complicated. And another reason why we see so much morbidity from the GI tract, and the small bowel is a really good example of that. You need the small bowel to be able to mix your food. You need it to be able to propel your food. You need it to be able to propel bacteria through the gut. And in the whole process of doing that, allow digestion, absorption of nutrients without absorption with bringing fluid back and not to allow too much fluid to be lost from the gut. These things are all happening in a very complex and very measured and very specific way. And you only have to perturb that by affecting the nerves within the gut, the fibrosis within the gut to a certain degree, to mean that process just isn't working properly. So the first thing you have is symptoms, but then you start malabsorbing, then you can have distension, and then you run into real problems. So you can see that you only need a little bit of an effect on the gut to cause problems. And the anorectum, which again, often not asked about, but a huge problem, is that one of the things that scleroderma does to the gut as it affects the smooth muscle is affect the anorectum, which I'll talk about as well. And it does that in multiple ways, but one of the most obvious is that it affects the muscle of continence, what we call the internal anal sphincter, which usually holds everything in and relaxes only when one wants to go to the toilet, and gets weaker with everyone with age, but does get much more weaker much more quickly in those with scleroderma, and that can obviously lead to significant problems across time. This is a very old slide, and we don't use this type of manometry anymore, but it's just to, we use what's called high resolution manometry, which is much more colourful and easier to read. But it's just to make the point that usually if you look chronologically from the top to the bottom, down and across down the body and across time across the bottom, when you swallow, you should see contractions going all the way down the esophagus. What happens in systemic sclerosis typically is you initiate the swallow, you can get food to the back of the throat, but then at its worst, nothing really is happening below then. And then the sphincter at the bottom of the gullet, which should be stopping everything coming up, is also ineffective. So you have gravity taking your food down and you don't have muscle trying to prevent you putting food back up again. So it's a perfect storm which we need to manage. Now, how common are these symptoms? We've looked at these in multiple studies. We looked at them at the Royal Free some years ago with Nora Thur. And it's just to make the point, if this is hard to read, that very few, 2 to 3% of patients that we surveyed within the clinic had no symptoms. That's hardly any. 10% had very severe symptoms, and 15% had a serious effect on their well-being. So that's higher in most surveys than most of the symptomatic problems people develop from other organ damage within scleroderma. Now, just to make the point again, if you look on the far left, there's a huge problem with upper GI symptoms in most scleroderma patients. And all of the other ones, you can't really read there, I'm sure, but reflux, distension, diarrhea, constipation, abdominal pain, and then social and emotional well-being. Most patients are affected for several days a week, and some for many more days than that. Now, the pathology here is multifactorial. There certainly will be vascular changes, as has been discussed by Mark, I'm sure, very early. But you do end up through the whole of this problem, ending up with smooth muscle atrophy and collagen deposition. That then leads to the bowel not contracting properly or in an organized way, which is very important. You can't have contraction on its own without organization of those contractions. And then you lead to problems because you're not clearing the gut. So you have anatomical problems where the gut doesn't function as it should. Bacteria in parts of the gut they wouldn't normally be, so they can overgrow. You get dysbiosis within the small bowel, leading to the increase in fluid and gas and discomfort. You can get dysmotility within the gut to the extent that the gut is getting very dilated and big. If that happens, it can turn. That's called a volvulus, almost like putting a balloon round on itself and blocking it off can be very uncomfortable and lead to mechanical obstruction. And there's a condition called pneumatosis where the bowel is so dysfunctional, if you like, that you get gas organisms within the bowel wall. And although that's not a surgical emergency, it can be misinterpreted as such on imaging. So there will have been scleroderma patients in the past who have completely unnecessary big operations on their abdomen for a condition that actually can be treated with medical therapy. So I've talked about the upper GI symptoms. I haven't got another specific slide on that, but just rest assured, I think I've told you enough on that. When I talk about GI scleroderma, we see these patients a lot as inpatients. This is really getting to the severe end of the spectrum. If the gut doesn't work properly, then you tend to not absorb your food. You have lots of flatus. You can get early satiety, which is an inability to, it means you get full very early, a lot of pain, swinging between diarrhea and constipation. And when it gets very severe, a condition called pseudo-obstruction where the gut dilates but doesn't really have a chance to start contracting again, which needs often hospital care, medication, support, fluids, and some nutrition to get things going. And of course, this is the severe end of the spectrum. Remember, I'm talking about, on our surveys, at least around 8% of patients. So this isn't the majority, rest assured, but those that do get these problems do need specialist help. And I won't go through all of these. There's lots of tests that we do. I'd just like to make one point on this slide, though, is that people with scleroderma, patients with scleroderma, are people who have other problems with their gut as well. If you like, I've seen the opposite happen in scleroderma care, which is that once you have scleroderma, you're considered too complicated by just about everyone you see, and you can have, therefore, I think I'm preaching to the converted, you can have very straightforward gastrointestinal problems, which we all get, which are put under the umbrella of too complex to deal with, and then patients get caught in a vortex of waiting for secondary care and hospital appointments to see gastroenterologists about things that really need dealing with. I'll give you a good example. Colorectal cancer is common, 1 in 20 of the population. Patients with scleroderma get colorectal cancer as well. If people with very severe lower GI symptoms are put into routine piles for treatment for abrupt changes in bowel habit and rectal bleeding, it's certainly not helpful for them. So it's just to make the point, we need to investigate for other causes. But then the other end of the spectrum, once we've done the investigations, we know that this is all associated with GI scleroderma. We really do need then to concentrate on treating the problems as best we can. And one of my at the other end of the spectrum is once you have ruled out other causes of problems, is not to treat patients by investigation, which is another thing that gastroenterologists tend to do. So if anyone in the audience has had 17 colonoscopies for the same symptom, they'll know what I'm talking about. Okay. Now, I just might want to make a point. This is the universal screening tool for nutrition, less relevant for primary care, certainly really relevant for hospital care. And just to say that patients with scleroderma do get malnutrition very easily, and it's often missed when they have their patient care. And we've really driven this internally at the Royal Free, certainly, as something that's an assessment for all those that get admitted and then to deal with it. Now, that's, if you like, the doom and gloom. So what are we going to try and do in terms of treatment? So one of the problems we have in systemic sclerosis and gut disease is exactly what Marco was just talking about in his slides. And I'd argue that the purple GI bar that was at the bottom of all the slides and where they present is probably way left. It's probably in the pre-scleroderma area, actually. And the reason I mean that is once you start getting damage to the myenteric plexus within the gut, we haven't found any way to reverse that. So If you come to us with significant symptoms of scleroderma and you are starting on mycophenolate and cyclophosphamide, if you are given most treatments for your heart and lung, or your lung fibrosis or your heart involvement, the sad thing at the moment is that will not affect your gut symptoms. And I suspect that's because the gut problems have happened way before we actually get to try and treat them. The one good thing we have found is that those that have overlap with myositis, so have muscle involvement in an overlap syndrome, if you have muscle involvement, then treating with immunoglobulin can be helpful for these patients. And we've done that in a series of patients at the Royal Free, and that has worked very well. And it's the one time, and it's always a very good time, if someone has myositis and scleroderma, where we can actually really improve their swallowing if some of their swallowing is based on the muscle that's higher up in the gullet. That can happen as well. So we've certainly had some success with those patients. And what can we do about anorectal problems? So I just want to talk through this again. Anorectal scleroderma is really prevalent. It's a big problem. It's not asked enough about, and we don't do enough about it in the clinic, I don't think, as gastroenterologists and surgeons. I think historically, we've been very surgically orientated with these problems, and that hasn't necessarily been helpful because unless you have functional muscle to bring together, for example, then doing any sort of surgery on the anal canal is not going to be helpful. There have been a whole series of interventions, I'll talk about some soon, which have not been as effective as we thought they would be. We were using bulking agents for some years to try and increase pressures in the anal canal. They did lead to infection and problems. We don't tend to use them, certainly not in our institution now. And because there's other problems associated with rectal compliance with the gut in general, just focusing on one area isn't necessarily very helpful. So we really need, if we're going to do interventions, we need to think more holistically about how we improve the areas outside the anus and in terms of the pelvis, and that comes with biofeedback therapy and pelvic physiotherapy, and some sort of intervention that will increase pressures and improve symptoms without causing even more damage to the area. So that's where our focus is with treatment at the moment. The problem we have is that, and that doesn't mean it, I spent years at St Mark's looking at these, and I always thought they didn't really look like much, but I told Professor Cam at St Mark's that I knew exactly what I was looking at when he showed me the squiffy lines there. But basically, it's trying to make the point that the internal sphincter, there's an external sphincter, the outside muscle, which is like your biceps, the one you squeeze when you want to stop yourself going to the toilet, that remains intact in scleroderma. The one on the inside, it atrophies, it gets very, very thin, and the pressures fall, and that's why things may leak. But also, when you do get the urgency, it's almost impossible to hold on because it's too late. So you need to deal with muscle that doesn't function well rather than trying to tie muscle together and give it a barrier. So we did used to use a lot of sacral nerve stimulation. There's some good studies, and they were going on many years ago when I was a research fellow at St Mark's, so that's how long ago we were trying this. We used to do a lot, or some at the Royal Free as well. Actually, although there has been some improvement in some patients, and I don't know if any of them are here today, it's no more than 50-50 across, and there's probably a bit of placebo effect as well. So it's a fairly big intervention for something that doesn't seem to work particularly well, I would say. We have had some success, and again, some of you may have had this with posterior tibial nerve stimulation. That's stimulating behind the ankle, actually, to the posterior tibial nerve right here. And doing that for an hour or so a week, every week. And that has had an effect. It works on a reflex arc via your sacrum, so the nerve goes back. Reflex arc, increasing tone within the anal canal, can be quite effective. Licensing for this indication isn't really particularly there for funding in certain institutions, so it can be hard to get. And actually, it hasn't been shown to be fully effective for other causes of fecal incontinence. So some services have this, and if you do have access to it, I would recommend a trial at least, because some patients at least find this very, very helpful for the fecal incontinence indication. Now, we got together some years ago, realising that there was a disparity in care across the UK, certainly, and we got gastroenterologists, surgeons. Chris was leading from the front from rheumatology, and radiologists and patient group as well at the time. Some of you may have been involved to try and get some sort of best practice for gastrointestinal care. This really is looking at patients in a situation in which the disease is well established and we are treating rather than the patients that Marco was talking about right at the beginning, where we're trying to be more aggressive with treatment. So we were looking more holistically a lot across symptoms rather than specific diagnoses, on the grounds that at least at some point there was always a point where you should respond for management. All of these organograms are changing. We will have new treatments as time goes on, but there are groups, as you'll be aware, working to try and improve treatment for the scleroderma cohort. Now, drug therapies, I only put this up because there aren't actually that many new drugs for gastrointestinal scleroderma, I'll be honest. And they've had very marked and variable results in the studies that they've been used on. We'd just like to mention some. There is data on rifaximin for small intestinal bacterial overgrowth. Very easy to use in Italy, almost impossible to use in the UK because it's so expensive, which the pharmacy at the Royal Free is very upset with me about, but it can be effective for that indication. We do use prucalopride. Prucalopride works at trying to reinstill peristalsis within the lower GI tract, but there's also receptors in the stomach. It's a serotonin receptor, so it can be helpful, we think, for some people with resistant reflux and a more of a constipation phenotype. The issue here is if you have diarrhea and you've already got problems with holding on to stool, prucalopride can be disastrous in terms of giving you even worse diarrhea, but certainly very good if the gut isn't working. And the other agents at the bottom, just want to point out, these are not treatments for GI scleroderma. They are treatments that have been given for other reasons that have then led to improvement in the conditions that are mentioned here. But they are not treatments for scleroderma at the moment. They're treatments that have been tried that have independently led to improvements in symptoms. So lots of words there, but just to tell you, if you do give rifaximin to patients with small intestinal bacterial overgrowth and scleroderma, then it does tend to be effective for some, but not all. It can be a good therapy and you can use it repeatedly. And this is obviously prime time because the use of probiotics for every single gastrointestinal indication, you would think, given what you will read and the adverts that you will see, I'd just be a bit mindful that we don't know which probiotics we should be given to which scleroderma patients yet, but there's clearly a lot of research we should be doing here. What is clear is there's dysbiosis within scleroderma patients. They do get bacterial overgrowth, but they also have, if you like, when I say dysbiosis, they have very different bacterial microbiota to other patients that don't have the disease. And there's clearly opportunity here and research that needs to be done to try and work on how we might improve things. It's very likely to be a secondary rather than a primary effect, but there's obviously more research to be done in this field. And just to let you know, prucalopride does help with constipation, which it should do. It's a drug for that, but it really does help in the scleroderma population, and we use it very frequently. It does need to be instigated in secondary care at the moment, but after the first prescription can be continued in primary care. Now, with a nod to my colleagues at the Royal Free, Dr. Christina Clark and Professor Denton, who's here, and others, autoantibodies in systemic sclerosis we know about. That's been talked about already. In terms of predicting GI involvement, we're only at the stage now where we see certain antibodies seem to have not predictive value, but are associated with particular antibody profiling. And actually, although this hasn't led to our ability yet to change our treatment strategies for individual patients, I think the really interesting thing here, much more in keeping with what Marco was talking about before, is that if we can phenotype our patients very precisely, and this is just one way we can do that, then we should be leading towards personalised care in the future. I have to say at the moment we don't have personalised GI care based on these associations, but it is yet more knowledge that we're working out in terms of what the associations are. And just to finally wrap up, just to say, we are working hard in this field, and you'll recognise, I'm sure, lots of the names on the list here. And these are two pieces of work that are just coming to publication fairly soon. So we are working, the conference obviously starts tomorrow, looking across the world really at how we can bring our expertise together to improve GI outcomes for scleroderma patients. And it's certainly work that will be ongoing. So in summary, often underreported GI symptoms, but they probably do come right at the beginning of the disease and potentially even before it presents. Significant morbidity, in some cases mortality, but that is the minority of patients, please be rest assured. Severe gut disease, however, is associated with mortality, and it tends to be the associations with other organ failure or intestinal failure. We haven't found specific correlation with disease type. We haven't found that. We found some associations, but it's not specific. You do need multidisciplinary care because in isolation, we all need to work together on these complex problems. And there aren't new treatments emerging, but we don't have the answers yet. But as I said on the last slide, we're trying very hard to find them. Thanks very much. Yeah, of course. Yes, and sorry. Should I do the? You got your hand up first.
Thank you so much for such a great talk. I was wondering if we have a better idea now why the gastrointestinal system is affected the way that it is in scleroderma, because I can understand why for patients, and even, when you go and see a GP, when a condition's got skin hardening and kind of vascular involvement, there's a bit of confusion as, okay, so why is the gastrointestinal system involved and why is it presenting the way that it is? So for years, it feels like that was maybe kind of why symptoms were dismissed so much, because the connection wasn't clear. So do we have a better idea now of why it causes the problems it does?
Well, I think I'm just trying to frame this correctly, because I think we do have a better idea, but I think the problem is that, yes, you get skin hardening, yes, you get vasculopathy, but you get it in your whole body, essentially. And the problem with the gut is that you only need the slightest of insults to the gut, whether it be the esophagus, the small bowel, the colon, or in fact the anorectum, to have very, very profound effects on function. So if I give you a little bit of vasculopathy around the myenteric plexus, for example, which we've seen in autopsies in scleroderma patients, if I give you a tiny bit of damage to your nerves caused by vasculopathy around the nerves, you'll lose function. And at the moment, we can't bring that function back. And I think that probably happens very early on in the disease. And going back to the pre-scleroderma question, I think one of the things I've always thought about is that, we have to think about how we're going to study that, because if we're going to make interventions, they're probably going to be before there's any sign of the disease to actually genuinely reverse the side effects on the gut, which I think are almost earlier than many of the others. That makes sense. So microphone over there. Hello.
That young woman covered some of my question, but I'm interested because I have severe GI involvement.
Yes.
And
sorry to hear that.
That's led to me having a stoma.
Yes.
And that hasn't been mentioned as sort of.
I'm really sorry not to have mentioned that.
No, that's fine. It's just I just thought I'd get it in there because that was. But I notice on all my sheets, reports and scopes and everything, that it says no comorbidities, no current treatments, and I'm on rituximab and mycophenolate, and it says functional. It has this word functional bowel problems, functional GI problems, and I wondered, is the word functional appropriate in the context of scleroderma?
So no. So functional gastrointestinal disorders are very real, and you have a disorder of function caused by scleroderma, but it's not functional gastrointestinal disorder, which implies you have irritable bowel syndrome, which apparently is very severe because you have a stoma. I know exactly what you mean, and I'm sorry to hear that the no comorbidities things must be infuriating.
Thank you.
Okay.